And here it is, spinothalamic tract. What a nice segue. So this is the spinothalamic. Again, we see three neurons over here. However, the very, very significant difference is that it decussates immediately. As soon as it goes into the spinal cord, it decussates, and then it starts climbing up or ascend towards the cortex. So any lesion over here, A, B, C, or D, would mean contralateral deficits. The only way this could lead to any lesion over here could lead to ipsilateral deficits is if it's going to happen at the very site of the lesion. So for example, if this is T10 like we saw with that guy before, and the lesion is right here, so this neuron over here entering the spinal cord is going to be deficient, not the secondary, but the first one. So only at the very level of the lesion will you see pain and temperature deficient ipsilaterally. Anything else is going to be contralateral. Romberg sign, yes. So there's a question, request to go over this again. Patient comes in, they're imbalanced. They find it very hard to be balanced. They're almost falling down, but kind of managing it. You're asking them to stand with their back to the wall, feet together. It's pretty difficult because the center of gravity now is very narrow, but they kind of make it somehow, with their eyes open. And then when they close their eyes, they almost fall down completely. The reason is because sensory information from the body in this patient is not making it into the spinal cord too well because there's a lesion somewhere that is damaging the medial lemniscal system. But the eyes are open, so visual system compensates. They can see that they're standing on the floor, so they're more balanced, approximately as much as they can, as opposed to when the eyes are closed and they don't have that information, then they're more likely to fall down. So for questions that you might see a vignette explaining exactly what I just explained, and then a patient is experiencing imbalance, and the symptoms worsen when the eyes are closed. What do you think is happening over here? And the answer is going to be the medial lemniscal system. It's not going to be the spinothalamic because it's way more than pain and temperature. It's just the touch and vibration. So just feedback from the world. I'm standing on the floor right now. That's not working too well. It's definitely not corticospinal because the patient should be having no trouble moving their limbs. And it's not cerebellar because, as I will tell you later on, if there's a cerebellar lesion, there's going to be imbalance as well, but the eyes are not going to help. The imbalance is going to be equal whether the eyes are open or closed. Tract intact, rostrum to the lesion, meaning towards the head, so above the lesion. So, Melina, it seems like uh, the issue may be on your end. So if you can check your Wi-Fi connection or move somewhere else, yeah, I think because it seems like no one else is having those issues. You might want to check the connection you currently have on your device. Spinothalamic tract, again, that's actually the same picture from before. And then spinocerebellar. For spinocerebellar, what we have is all ipsilateral information coming from the spinal cord towards the cerebellum, telling the cerebellum at each point which muscle is contracted and which isn't, so the cerebellum can initiate automatic movements that are subconscious and involuntary that we don't even think about, pretty automatic, and that's all ipsilateral. Yes, so the Romberg sign only positive for medial lemniscus or for A and B. Oh, do you mean the lesions? So the lesions over here, it really doesn't matter where the lesion is, as long as it's for the medial lemniscal system, you'll see Romberg. Could be above the decussation, could be below the decussation. It doesn't matter. Romberg sign is when this tract specifically is lesioned, not the spinocerebellar, not the corticospinal, not the spinothalamic, only this medial lemniscal system. Okay, and now what I'm going to do is I'm going to use this information that I just gave you, and I'm going to be talking about different syndromes that have to do with lesions to the spinal cord. Let's start with the poliomyelitis. That means selective destruction for lower motor neurons specifically. And if the lower motor neurons specifically are deficient, what do you expect to see? Flaccid paralysis. So people with polio, historically, before we had the vaccination for that, you used to see people in wheelchairs finding it hard to stand up and move. Limbs are very flaccid. That's classic presentation of poliomyelitis. You see hyporeflexia, not enough reflexes, and hypotonicity. Tonicity is the contraction that each and every muscle in our body has at any point. They're never completely loose. They're always slightly contracted, and then they contract even more when we have to move some bone in one direction or another. So hypotonicity means that less constant tonus. And here is where this is happening. So this is ventral, this is dorsal. You're looking at the spinal cord. These are the secondary or lower motor neurons exiting the spinal cord. And this is where this deficit takes place. Amyotrophic lateral sclerosis. So the progressive degeneration of nerve cells in the spinal cord and the brain. It's pure motor. Any deficits you'll see with that are pure motor. It affects both upper and lower motor neurons, so not just lower anymore. Starts from cervical regions and then it progresses, could progress upwards, downwards, or both. We're going to see, usually at the beginning of this condition, flaccid weakness in the upper limbs and spastic in the lower. The reason for this is because the brachial plexus going to the upper limbs from the neck region over here, that's higher up. That's in the cervical region. So flaccid paralysis to upper limbs because the brachial plexus is found so high up in the cervical region that lower motor neurons, the ones that actually leave the spinal cord and go to the muscles, they're found already in the cervical region as well. So if there's something wrong in the cervical region, it's going to be upper and lower motor neurons. So if the lower motor neurons are involved, you'll see flaccid paralysis, flaccid weakness. For lower limbs, the lower motor neurons are found way down, way more inferiorly. So in the cervical region, it's going to be the upper motor neurons for those limbs specifically that are deficient. So we're going to see spastic weakness for the lower limbs. Unfortunately, as it progresses, everything becomes flaccid because all lower motor neurons are going to be affected eventually. Anterior spinal artery occlusion. This is again the spinal artery. This is the anterior aspect or ventral. This is the dorsal. Just to let you know, we're about to take a break in about 5 minutes. So the anterior spinal artery provides blood to this anterior region. The posterior or spinal arteries provide blood to this posterior region. They do anastomose or connect via this lateral spinal artery, but this is a tiny little anastomosis. Mostly it is the anterior spinal artery that is in charge of the ventral aspect and the posterior for the posterior aspect. So if anything happens to the anterior spinal artery, if it's occluded, if there's no blood supply here, what do we see affected? Well, first of all, corticospinal tracts, and you'll see that as a theme as I go over other regions in the midbrain as well. Anything anterior is usually motor, anything posterior is usually sensory. So as you hear about the anterior spinal artery being affected, the first thing you want to think about is the corticospinal tract and the motor tracts being affected. Below the level of the lesion, the patient exhibit bilateral spastic paresis and bilateral loss of pain and temperature as well. Why pain and temperature? Well, spinothalamic tract, right, the one for pain and temperature, this guy's found very anterior in the spinal cord. It's going to be slightly more posterior in the brainstem, but in the spinal cord, it's very anterior. So pain and temperature is going to be affected as well. Notice that it's bilateral this time as opposed to ipsi or contra, simply because this artery provides blood to both sides. So if you see flaccid or spastic paresis on one side of the body, you want to think about nerves. If you find them in both sides of the body, first of all, you want to think about arteries. It is possible for both places in the spinal cord to be lesioned, the nerves themselves, but it's highly unlikely. It's most likely there's an artery occluded if you see it bilaterally. Is proprioception, vibration, and vibration spared? Yes, those are found more posteriorly. So those are going to be spared. That's the posterior column. Awesome. Okay, thank you. The bladder, it says over here, spastic bladder. So just to let you know, spastic bladder will happen in a lesion above the sacrospinal roots, and an atonic bladder will be seen when there's a lesion below that level to the sacrospinal roots themselves. Why? Simply because above the sacral spinal roots, that means the sympathetic system is affected, so there's no inhibition of the parasympathetic system. So spastic bladder means the detrusor muscle is constantly contracting with no inhibition. So that's a spastic bladder, constant need to go to the bathroom. But if the sacral spinal nerves are affected, that is the parasympathetic system. So that means that the detrusor is not going to be able to contract, and the person would not feel the need to go to the bathroom, or they will feel the need but will not be able to initiate urination. And then there's going to be a continuous dribble because the bladder is going to be way too full. Occlusion. Yes, occlusion. So when I say occlusion, it's just a blocking. The artery is blocked. There's no blood flow. If the anterior artery is occluded or blocked, what we're going to be seeing is motor deficits plus pain and temperature deficits. But if the posterior one is occluded, and that's less likely actually to happen, which is why I didn't bring it as a an example, because there's two of them. So for the two of them to be occluded, it's very rare. So there's always one protecting the other. But if anything happens posteriorly over here, it's going to be um, the medial lemniscal system that is affected. Usually anterior is motor, posterior is sensory. There are some exceptions, like this spinothalamic tract over here for pain and temperature, which is anterior. And Romberg side. So the Rosenberg, you mean Romberg, right? So for the Romberg sign, let me just, because we're at time, let us just take a break right now. It's 9:20 for me in Central Time. We'll take a break for 10 minutes. When we come back, I'll start with the Romberg sign and then I'll go on with the other slides. Okay, so let's take a 10-minute break. We'll get back here and we'll continue with this high-yield review of neuroanatomy.